Bagus sana.
Ikut awal sikit lah boleh record the banter sikit.
Bijak lah.
Go live. Go live.
Go your video.
Weh, jangan buat live tu.
Nampak.
Discord.
Oish, bra.
Oi,
Oh,
dia dah
Bra,
tak
bra.
sabar. Dia dah tak sabar nama PUBG ni. PUBG PC.
ni payung lu.
Payung bajet PC lah boys.
Payung lu.
Oh, bajet 1,400 lah.
Okey, lain.
Alright.
Jom.
Lai.
Lai.
Allahumma ta'ala himmatika syukran nabi. Okay, bismillahirrahmanirrahim. So, semua dengar kan? So, hari ni kita akan cerita sikit pasal nasopharyngeal carcinoma. So, this is fourth common carcinoma in Malaysia. Okay, selain daripada breast, daripada colorectal dengan lung cancer. So, ni cancer yang keempat. So, apa itu NPC? It's a nasopharyngeal carcinoma and is an epithelial malignant tumor of the nasopharynx. Maksudnya ada malignant tumor dekat kita punya nasopharynx. So, ni outline dia. So, ini anatomy of nasopharynx. Basically, kita dah banyak kali dah ulang. Which is nasopharynx tu belakang dia adalah cricoid cartilage, depan dia cricoid cartilage, belakang dia C6 vertebra. Maksudnya daripada cranial base sampai ke tempat
Hello.
Hello. Adakah PC dia terpadam? Hello.
Member okey tak?
Dan okey ada?
Dia okey.
skull kan, base of skull.
Oi.
Lepas tu
Kau terputus tadi.
Saya dengar.
hello?
Tadi terputus tadi.
Oh, tadi terputus.
Tadi cuba kau start balik yang
Daripada awal. Slide 1. Tak ada.
Tak. Yang anatomy. Okey.
Tadi terputus lah.
Betul tu.
Weh, harap ni. Okay, so tak ada apa pun first slide ni. Anatomy of nasopharynx ni kita tahu dia daripada cranial base. Kalau depan dia sampai cricoid cartilage, kalau belakang dia sampai C6 vertebra. Okay. So nasopharynx terbagi daripada 3, nasopharynx, oropharynx dengan laryngopharynx. Okay. So nanti ni kita dah tahu kan. So boundaries of nasopharynx, apa kita tahu, kita macam common sense. Okay, nasopharynx kat sini. So depan dia ni ada corona, ada meatus, ni semua ni nasocavity. Lepas tu rooftop dia ada macam bony part, which is a part of occipital bone kan kat belah belakang. Lepas tu kalau kita nampak dia ada pharyngeal torso kat sini. Kalau posterior part is a vertebra itself which is atlas, maksudnya dekat atas C1 tu kan. And then floor dia kalau kita tengok kat sini soft palate kat belakang kan, soft palate. Then yang paling penting lateral wall. So lateral wall kalau kita tengok kat sini, kita ada eustachian tube, which is dia situated 1.25 behind the posterior end of the inferior turbinate. Kalau kita nampak inferior turbinate yang ni, so 1.25 cm jarak dia, tapi tak perlu ingat kan. And then kalau kita tengok kat sini ada elevation, which is kita panggil dia tubal elevation. And then along the way dia turun ke bawah, akan ada salpingopharyngeal fold. Lepas tu kalau tengok kat belakang ni ada fossa. It's a common fossa of Rosenweiler. Okay. Itu je. So kalau tengok daripada scope, kita akan nampak ni torus of tuberous. Belakang dia ada fossa, nama dia fossa of Rosenweiler. So next is Possevin Ridge. Apa yang penting Possevin Ridge ni, dia nak bagi tahu kat sini. Hijau ni adalah ring. Ridge lah. Dia akan activated by the muscle of superior constrictor muscle, palatopharyngeal muscle, stylopharyngeal muscle, all the muscle of the self palate. So dia akan contract deglutition of speech. Deglutination of speech. So ini adalah untuk cut off between kita punya nasopharynx dengan oropharynx. Itu je lah. So kalau kita tengok tadi yang kita dia ada stylopharyngeal muscle, superior constrictor, ni daripada daripada belakang, which kita nampak palato pharyngeal muscle. Okay. To all the muscle lah yang contribute to the pasopharyngeal. So neck is a content of nasopharynx, dalam dia ada tubular tonsil, left and right, and then kita ada adenode, which is yang kat atas tadi tu. Okay. So kalau kita tengok kat sini, ini adalah scope daripada bawah, daripada anak tekak sini. Daripada lubang hidung belah kiri. So kalau kita tengok daripada belah kiri, lateral part ni ada lateral part kan. Lateral part kita akan nampak ni lah, ada fossa of rosomula, which is saphingopharyngeal fold. Atas dia tadi kan, torus, which is tubal elevation. Ni kalau kita tengok ada eustachian tube. Okay. So next is benda ni, dia lined by the pseudostratified ciliated columnar epithelium. Terus supply kat situ adalah ascending pharyngeal branch of the external carotid artery. Dia ada dua, kiri kanan. Venous drainage dia pharyngeal venous plexus. Lymphatic drainage dia adalah retropharyngeal and upper deep cervical chain node. Okay. So for the epidemiology, usually case ni increasing in worldwide. Kalau kita tengok dia ada dekat Southeast Asia and Southern China. So in Malaysia, dia adalah the fourth most common cancer. Dia selalunya dalam male, 3:1 ratio. Most common group age is 40 to 60, but ada detect NPC ni dekat 6 years old. Ada satu case lah. And then dalam races, Chinese the most lah. And then for risk factor, kita boleh bagikan dia kepada genetic, environmental and also viral. So for the genetic, tadi kita cakap dia from the Southern China and Southeast Asia, like in Taiwan. And then even kalau dia datang dari situ, kalau dia migrate as well, tapi the risk retain dekat dalam orang tu. Because dia cakap kat sini dia associated with the certain HLA yang discovered by the Taiwan. And then it's also associated with the genetic polymorphism of a nitrosamine metabolism gene. Kira basically NPC ni nitrosamine yang penyebab dia. And then for the environmental causes, for in dietary, in patient yang ada dietary intake of high content of nitrosamine like in the salted fish, patient with vitamin C deficiency. Kenapa? Because this vitamin C, dia akan block the conversion of the amine into the nitrosamine by the nitrosification. So daripada amine ke nitrosamine by the nitrosification, so vitamin C ni akan block. So in patient yang ada vitamin C deficiency, dia tak akan block lah. So terjadi nitrosamine ni banyak. So lagi satu, high consumption of preserved food like macam tin dalam sardin tu kan. And then burning thing with like macam incense wood sebab dia ada polycyclic hydrocarbon. And then receptor smoking. So for the viral infection like in the EBV akan macam associated with the development of NPC lah, Epstein-Barr virus. Sebab effect of the EBV on the development is secondary effect. So the virus impairs the tumor suppression. So akan menyebabkan NPC lah. Okay. Two important antigen is a viral caspid antigen and also early antigen. So dia cakap kat sini, IgA antibody of the EA ni apa? Highly specific for the nasopharyngeal carcinoma. Which ni lah, the IgA antibody for the early antigen ni highly specific for the nasopharyngeal carcinoma. So in EBV ni dia suppress these two things lah, akan menyebabkan NPC lah. So actually kita boleh buat screening lah untuk check these two antigen. Okay. And then grossly the tumor present in three form. The first one is proliferative, second one is ulcerative and lastly infiltrative. So kalau proliferative tu kita ada nampak polypoid tumor penuh kat dalam nasopharynx tu. So selalunya dia punya presentation is obstructive nasal symptom like macam tersumbat hidung ke apa ke, tak ada bau ke. And then ulcerative, bila dia ada ulcer, so dia akan ada macam bleeding, so akan epistaxis. And then infiltrative maksudnya dia dah masuk ke submucosa. So mode of spread, they can be local spread, which is the commonest part tadi ni yang penting dia fossa of Rosenmuller. Dia belakang tadi, tubal elevation tadi. So the anteriorly, kalau ada berlaku kat situ, local spread, so dia akan obstruct kawasan situ kan. Dia akan spread ke depan, dia pergi oscillation tube tadi kan. Ke depan kan. Ke bawah sikit. And then dia block the corona, block the nasal cavity. Kalau belakang, dia pergi ke bawah kan. Dia pergi ke bawah like oropharynx, hypopharynx. Ke tepi, pergi ke pharyngeal space. And then ke atas dia pergi ke ni intracranial structure lah. So selalunya cranial nerve 6 is always the first to be involved. Ni lah tadi dia pergi ke atas, pergi ke corona, pergi oscillation tube. Okay. Ke belakang retropharyngeal space. So next dia boleh spread to the lymphatic spread. Usually lymphatic spread is ipsilateral more often. Okay, so usually kalau cervical nerve ni, the involvement of retropharyngeal nerve, so they causing neck stiffness. Then dia boleh distant metastasis like to bone. Selalunya bone commonest in NPC lah. Other than that can be lung, liver. So for the clinical feature, kalau site dia tu kat nasal, so adalah obstruction, discharge, epistaxis, ni di nasal speech. Macam sengau lah. Okay. And then otologic, ke oscillation tube, dia obstruct the oscillation tube. Lepas tu adalah complication dia, kita ada conductive hearing loss, otitis media, tinnitus, dizziness. And then ophthalmoneurologic, dia akan extend ke atas kan, dia pergi cranial nerve. 6 tadi yang mula-mula kan. So if kalau dia affect certain cranial nerve, kalau cranial tu ophthalmic, dia akan blindness, CN3 optic, CN3 ophthalmic, abduction semua ni dia akan ophthalmoplegia. Okay. So ni CN6 juga abduction. So dia akan squint ke dia poplar sebab 6 ni kan untuk function muscle, mata semua. And then 7 focal pain, reduce corneal reflex. Basically ni lah, commenting lah. Apa-apa yang effect dekat cranial nerve tu. So next is cervical node metastasis. It's a most common and initial presentation, usually bilateral manifestation when first seen. Tadi dia ada cakap tadi kan, so usually kalau ada macam lymphatic spread, dia akan pergi ke cervical node, dia akan cakap dia usually unilateral. Tapi usually kalau kita detect dia kat patient, dia dah bilaterally. Okay. Usually kita akan nampak lam baru kita perasan kan patient tu ada metastasis kat certain part dekat cervical node. And then this metastasis yang tadi aku cakap So usually patient cakap dia ada cervical dia datang dengan cervical lymphadenopathy lah. Dia punya causes dia. Okay. Dia punya presentation dia. So ni tadilah dia apa summarize dalam satu slide. Kalau tengok session tu OM, nose, nasal obstruction, dyslexia semua. Okay. So for the investigation, okay, take a deep breath, stretching sikit-sikit Jom sambung.
Baik. Tak nampak.
Baik.
So
dah
for
sambung.
investigation, they can be baseline investigation and also histopathology and cytology. Okay. So dia cakap sini biopsy is a mandatory. So according to the WHO classification of the tumor pathology and genetic and semua, kita buat FNAC. Dia punya ni recommendation dia. So dia macam mana cakap dia ada turutan dia lah. Biopsy ni mandatory tapi kita kena tengok classification dulu. Baru last kali kita buat nasopharyngoscopy lah. And then so according kita tengok dulu dia punya WHO classification. So dia ada 3 jenis lah korang boleh pakai. 2005, 1991, 1998. So actually ni dia punya classification dia, kalau WHO classification 2005 dia ada creatinous squamous cell carcinoma, non-creatinous carcinoma, differentiated, undifferentiated. Ni boleh baca sendiri kan. Squamous cell carcinoma, differentiated. Okay. So 78 dia guna ni type 1, type 2, type 3, which is sama je sebenarnya. Squamous cell carcinoma, non-creatinous, undifferentiated, and no synonym exists. Okay. So recommendation 2. Nasopharyngoscopy should be performed in all patients suspected NPC tadi. Tapi NPC should be diagnosed by the histopathology examination of the nasopharynx. So kena buat biopsy lah ni. So in patient presenting with cervical lymphadenopathy, full head and neck assessment and fine needle aspiration, cytology examination of the node should be done. Yep. Aku pernah baca tak ingat lah macam mana dia punya ni. Okay. Dia nak cakap sini lah. So recommended ni dalam CPG lah dapat So NPC ni sepatutnya dia buat dekat dalam patient yang suspected NPC lah. Okay. Tapi kita nak diagnose NPC tu kena pakai ni, kena buat biopsi lah untuk ambil dia punya histopathological examination. So tapi in patient yang ada cervical lymphadenopathy, kita kena buat full head and neck assessment and kita kena buat fine needle aspiration cytologic examination of the node should be done. Okay. Ni tadi. Okay. So kita move on to staging. So staging macam biasa lah, dia guna TNM staging lah. So kalau T kita nak tengok ya. Tumor itself dia boleh jadi kalau kita tengok situ kan TX primary tumor cannot be assessed, T0 no evidence of primary ni TIS carcinoma in situ. So in nasopharynx T1 ni dia confined to the nasopharynx or the tumor extend to oropharynx dengan nasocavity without parapharyngeal extension. Maksudnya tak ada pergi parapharyngeal lah. Kalau T2 ni dia pergi parapharyngeal extension. Tapi kalau T3 ni dia naik atas, dia pergi ke skull. Kalau T4 ni dia ada intracranial extension, involvement cranial nerve, semua tu lah. Dia memang ada teruk lah ni. Okay. So N lymph node lah. So kita nak tengok regional lymph node cannot be accessed and O no regional lymph node metastasis. So kalau in nasopharynx start di N1. N1 ni kita akan nampak unilateral metastasis in the cervical lymph node which is less than 6 meter. Okay. So kalau N2 dia ada bilateral metastasis, maksud dia bilateral, also less than 6 meter which is 6 and less lah. And then N3 ni bila metastasis tadi kat dalam lymph node tak kisahlah unilateral ke bilateral ke, tapi dia dah more than 6 meter. N3A is more 6 meter in dimension. Okay, lagi besar lah, maksudnya 6 kali 6. Tadi less than 6 lah, ni more than 6. And 3B is dia ada extension to the supraclavicular fossa. Okay. So distant metastasis senang lah. Dia MO no distant. Kalau M1 dia ada distant. So kalau kita nak tengok kat sini. Kalau kita perasan lah. Kalau dia ada metastasis kita cakap betul stage paling teruk lah. IV stage 4C. Okay. So kalau stage 0 tu dia tak ada semua, tak ada, cuma dia ada tumor lah. Carcinoma in situ. Stage 1 dia ada T1, dia pergi ke oral cavity semua tadi kan. Stage 2, pandai aku baca lah ni. So for the imaging kita akan buat CT scan. Okay. And then untuk check neck node lah for the cervical lymphadenopathy. So kita boleh buat MRI. Kita nak tengok soft tissue. And then extension lah kalau ada extension tu ada pipe. And then kita buat PET scan. Ni untuk advanced stage 3 and 4. So treatment and follow up. kita boleh bagi pada dua, which is primary cancer newly diagnosed. So kita buat radiotherapy, chemotherapy. Untuk recurrent cancer, kita buat endoscopic nasopharyngectomy, conventional nasopharyngectomy dengan radial neck dissection. Ni untuk surgically lah sini. So kalau kita tengok sini, ni dia punya management lah. So from the history taking, physical examination. So kita buat nasopharyngeal examination biopsy plus minus FNSO of the regional lymph node. Kalau ada involve kena buat lah. And then baseline investigation, kita buat full blood count, renal profile, renal blood sugar semua, MRI, CT, PET CT semua. So untuk determine disease stage, untuk determine treatment, okay, kita kena based on the stage itself lah. So kalau stage 1, treatment dia macam ni, okay. So dia akan pakai radiotherapy, okay, definite radiotherapy. Actually ni kena tahu kan. So primary site total of 66 to 73 gray for 33 to 35 fraction. Treated 1 fraction per day for 6 to 7 week. Dari 33 fraction. So kita kena habiskan 1 fraction per day lah. Selalunya 33 hingga 35 ni 6 hingga 7 minggu lah. Okay. Lepas tu dia cakap 1.8 to 2.0 gray per fraction. Maksudnya untuk 66.7 gray ni kita kena ingat lah dia ada berapa fraction. Selalunya 33 hingga 35. 33 ni satu hari satu fraction. Tak salah aku tolak weekend lah. Lepas tu dia akan jadi 6 hingga 7 minggu. So dia punya treatment dia untuk ni lah, stage 1. So next is stage 2, stage 3, stage 4A and B lah. Basically ni tengah-tengah lah ni. So dia ada cisplatin plus radiotherapy. Sama juga dia kena habiskan 66 to 70 gray. Kita buat semua agak 33 to 35 fraction dalam masa 6 hingga 7 minggu. Itu kalau untuk primary site. Tapi kalau neck kita kurang sikit 54 hingga 70. So basically 54 hingga 70 gray ni ada 30 hingga 35 fraction. So sama juga kita buat 6 hingga 7 minggu. And then for the stage 4C, kita consider clinical trial if available, palliative chemotherapy. Kira ni memang dah tak boleh diselamatkan lah. So kita kena buat palliative care. Okay. Faham. Aku dah ingat balik lah apa tadi dia cakap dekat sini sebenarnya. Dia cakap kat sini, NPC semua kena suspect. Kalau kita suspect NPC memang kita kena buat. Kalau kita kena buat ni lah, nasopharyngeoscopy. Tapi nak diagnose tu kena buat histopathology, maksud kena buat biopsi lah. Tapi dia advance sikit dengan cervical lymphadenopathy. Kita kena ambil ni FNAC tadi, fine needle aspiration. Dekat tu lah tempat yang patutnya tu lah. Okay.
So maksudnya Sual, maksudnya kena buat scope, kena buat biopsi dan juga kena FNAC.
Yes.
Yang biopsi of the tumor ke?
Dia tumor.
Okay.
Betul kan? Aku ada salah.
Betul. Aku rasa betul sebab kita ambil biopsy from yang tumor tu. Lepas tu kalau yang FNAC tu aku rasa kalau patient baru ada cervical lymph baru kita buat.
Baru kita buat FNAC.
Dan kalau tadi kita buat ni je lah biopsi dekat hidung.
Maknanya FNAC tu kalau ada
cervical
lymphadenopathy Tapi basically 70% patient memang datang dengan cervical lymphadenopathy kan.
Nah, usually bilateral kan?
Dia usually datang dia bilateral lah.
Sebab masa unilateral dia tak kisah hari ke macam mana?
Tak pasti lah. Maybe dia tak ada macam ada simptom ke timbul ke apa ke. Macam tu lah. Tapi basically cakap lah, aku tak tahu nak cakap dia bilateral ke unilateral. Tapi usually dia datang bilaterally kan. Okay. So yang ni tadi faham kan? Grey semua tu kan? Okay. So for follow up, kita kena buat follow up lah untuk respon untuk tengok respon towards treatment, untuk manage side effect and complication, provide surveillance and early detection of local regional relapse. Okay, takut ada relapse lah. So for the follow up and surveillance, kita akan involve all the team lah yang terlibat like ENT, oncologist, speech therapist, audiologist. So head and neck system examination kita akan include sekali dengan nasopharyngoscopy lah, untuk tengok kan. So kalau first year kena, kita akan buat 1 to 2 month, second year 2 to 3 month, third year 3 to 5 month, and then 6 month, and then after 5 tahun kita check out every 6 to 12 month. So aku rasa tu je kot, tak ada apa. Okay, ada apa soalan?
Serius lah.
Serius lah?
Soal yang paskan bab waktu kita CPL tu, banyak doktor selalu tanya pasal the level of lymph node yang affected. Dah terbaca?
Itu aku tak terbaca tu. Aku membaca slide ni.
Nak share?
Okay, saya dah baca ni.
Okay, boleh lah share. Aku stop share.
Okay. Kejap saya macam nak buat. Okay. Kejap.
Syafiq nak share screen ke?
Hello. Saya baca kat ni.
Tak, Syafiq nak share screen ke?
Saya nak share screen sekejap kan.
Tapi saya nak cam show daripada Daniel.
Oh, nampak?
Kat phone lah.
Oi. Apa ni? Nampak? Nampak? Okay.
Nampak.
Ni dia cakap boom. 85% of NPC case daripada NCBI presented with lymphadenopathy, mostly ada lymphadenopathy lah. The most common involved region include retropharyngeal.
Oh, okay.
Retropharyngeal tahu kan? Dekat mana kejap.
Kat belakang.
Kat belakang. Pharyngeal lymph node bomb. Boom. Sini, belakang lah. Ada
Commonly the most common.
Most common.
Oh, retropharyngeal, okay.
Cuba. Ready? Okay. Most common 69% and level 2 70%. Level 2 tahu kat mana? Ya. Level 2. Hello?
Tak, peti.
Oh. Okay. Boom. Ni level 2.
Okay. Oh, ni kita tak
dekat juga level 2 dengan retropharyngeal.
Dekat. Retropharyngeal dalam ni kan. Ni level 2 kat sini. Tapi
retropharyngeal tu level 2 ke tak?
Bukan.
Level apa?
Dia along the way lah.
Dia
above.
Dia dalam.
Dia tak ada kena-mena dengan level 2.
Saya rasa dia dalam, dia internal. So kita clinically kita tak dapat pun yang retropharyngeal tu. Kita papik mana boleh rasa. So level 2 is the second most common. Lepas tu overall lagi 3, 4, 5. 3, 45, 4, 11, 5, 27%. 3, 4, 5. 5 I don't know which mana. So kalau patient ada LPC, kita papik sini.
So along sternocleidomastoid tu lah.
Sternocleidomastoid dan behindnya. Okay,
nice.
Boom.
Serius lah Dan.
Cak, yang tadi
Oi.
di atas tu.
Oi.
Okay tak?
SSD.
Mana SSD?
Tak dengar? Dan bunyi macam robot.
Ayo pun.
Tak dengar tu.
Lagi doh.
The fuck?
Dah keluar masuk dek.
Keluar lu, betul masuk balik.
Kau bunyi gini tak?
Dengar tak?
Tak, kau bunyi jam. Oi, kau dengar tak? Macam tu.
Tipu-tipu kan?
Ni dah okey
Betul lah,
pula.
betul lah. Apa?
Just
Ni dah okey dah, ni dah okey dah. Apa
Apa
tu
dia?
kau cakap ni?
Apa hang cakap ni?
Hello, tak?
Dengar tak?
Ni okey tak ni? Tadi
Okey
kan
tak?
yang superior border dia, dengar lah.
Speed border off.
Okay, superior border dia kan hayop bone Yang tadi tu, yang level 1, level 2 kan? Kan atas dia yang tu hayop bone
Ya, hayop bone.
Okay, tu critical cartilage kan?
Yes.
Okay, yang 7 tu just dekat retrosternal lah.
Retrosternal, yes.
Alright, mantap. Thank you.
Ni penting kan, level ni penting lah.
Alright, mantap.
Boom.
Ni sebelum exam kena tahu lah level ni. Dia boleh lembak ni.
Boom.
Aku tambah kat slide. Nanti baca balik.
Okey.
Alright. Okay.
Okay, then
Oi.
Okay, so kita ada few types of nasal septum pathology. We have deviated nasal septum, septum perforation, septum hematoma, septum abscess. So, the septum hematoma is an emergency case. Okay, so deviated nasal septum kita ada, okay apa? Kita start dengan nasal perforation. Okay, DNS lah ataupun deviated nasal septum. Okay, we have several types lah. Okay, the differentiation is which the septum instead of being placed central, dividing the nasal cavity into two equal chamber, is inclined to one side or other. So will it cause increase one cavity at the expense of the other. So one cavity tu akan besar and another one will be actually narrowed lah because of the deviated nasal septum. So the most common etiology is trauma. Alright. Next is errors of development, hereditary, high arch palate ataupun neoplasm in one side. Okay, so risk factor for deviated nasal septum, age, which is common in adults, sex, common in males, family history of DNS, birth molding theory lah, okay, in abnormal birth delivery. So incidence is about, neonatal septal division is about 4% only, but if patient ada external compression of the forces which is involved in maxilla, patient will come with flattening of the cheek, distortion of the palate, and also associated orthodontic abnormality. Okay, so ni macam associated symptom, sign lah. Patient ada flattening of cheek, okay, dia ada distortion of the palate and also orthodontic abnormality. Okay, these are the types of deviated nasal septum. Okay, kita normal, which is straight in line. C-shaped deviation, the cartilage actually has been crooked jadi C. Okay, and then S-shaped deviation, dislocation of the caudal septum, which is at the bawah tu. Bawah tu dia jadi distortion, ataupun dislocated. And the next one is septal spur. And the last one is thickening of the nasal septum. Okay, so investigation usually tak payah pun, tapi in order to rule out sinusitis, because patient yang datang with DNS akan ada chronic, atau ada symptoms of rhinosinusitis. So dia akan ada with the nasal discharge, dia akan ada facial pain, dia akan ada reduction of smell, anosmia. So it is relevant juga kita nak buat X-ray PNS to rule out sinusitis. Ataupun dia tak ada sinusitis, dia just deviated nasal septum, boleh cause that symptom juga. Okay, so rigid nasal endoscope is contraindicated in gross DNS. Kalau memang nampak sangat, tak payah buat lah. Okay, for treatment, surgery is the only treatment for obstructive and impacted DNS. Okay, and most common is septoplasty lah, ataupun submucous resection.
Kejap Dan.
Ayo.
Kenapa buat X-ray to rule out sinusitis?
Sebab kita tengok patient ada ni tak, underlying sinusitis tak? Rhinosinusitis.
Okay.
Sebab patient yang datang deviated nasal septum kan, dia mungkin ada underlying rhinosinusitis. Ataupun one of the cause of rhinosinusitis is deviated nasal septum.
Oh, okay.
Okay, alright. So patient yang DNS pun boleh datang with that rhinorrhea semua tu lah. Okay, complication, turbinates hypertrophy. Ini dekat normal side of the nasal cavity lah. Patient would have a turbinates hypertrophy. Okay, so nampak yang belah kanan pathogenesis, DNS will lead to compensatory hypertrophy of the turbinates of the opposite side. So more air entry on that side, dryness, cause vasoconstriction, and then will reflex vasodilated. Patient would have hypertrophic turbinates. So clinical features for
DNS, nasal obstruction lah very common sebab dia dah block. Okay, terminal mucosa is thick and also the inferior hypertrophy, inferior turbinate is hypertrophic. Okay, these are the contoh lah. Okay, kita punya nasal septum and then that's the hypertrophy of the inferior turbinate. Okay, so it includes treatment dia, reduction, treatment for hypertrophy turbinates is just kita kena reduce the turbinates. So kita kena buat surgery. Okay, these are the list of surgery punya option: linear cauterization, submucosal laser or total or partial turbinectomy. Aku rasa yang 5 tu common kot. And then caution, removal of turbinates can result in persistent crusting and atrophy. So sebab kita tak nak dalam hidung tu kosong tau. Sebab kosong, kalau rooming cavity, kita boleh leads to atrophic rhinitis. Ingat tak? Kan? So kita tak nak benda tu jadi. So kita kena just buat partial turbinectomy. Alright, okay, ni case of the septal perforation lah. Right. So definition dia, hole in the nasal septum through which direct communication occurs between both nasal cavity. So etiology dia, kita ada trauma which is surgical, repeated cauterization, constant nose picking. Okay, repeated cauterization ni in patient anterior epistaxis. Kita kena buat packing kan, ataupun kita kena buat cauterization. So kita silver nitrate cauterization tu kan, kita pump. Kalau repeated boleh jadi trauma and cause perforated. Diseases like TB, syphilis, atrophic rhinitis. Atrophic rhinitis pun boleh juga kalau dia persistent crusting lama-lama kan. So dia boleh cause perforation. Irritants like tobacco, cocaine snuff, and then others like Mendelian disease. Okay, septal perforation. So 4 stages. We have first one is redness and congestion. Alright, and then mucosa become blanch and anemic. And then bila anemic, dia tak jadi moist hidung tu. Jadi so ada formation of crust. So then crust will extend and causes perforation of cartilage and leads to septal perforation. So ni kita nak differentiate between small, medium and large. Kita pakai centimeter, which is less or equal than 1 centimeter is small. Medium 1 to 2 centimeter. Kalau large is more than 2 centimeter. Perforation is more common in the middle and inferior part of the septum. Okay. Okay, so ni. Okay, investigation kita. We have several investigation lah. Tapi tak payah pun sebenarnya. Tapi for hemoglobin to rule out anemia. Okay, ESR for chronic infection. If patient ada TB, ada syphilis ataupun other underlying infection pun kita boleh tahu by looking at ESR. Okay, rigid nasal endoscope. Nak tengok apa causes dia. X-ray PNS to rule out associated sinusitis. Okay, X-ray to rule out tuberculosis. If patient ada pulmonary tuberculosis, kita buat X-ray. UNC, urea creatinine, just to rule out vaginal granulomatosis. Nasal smear ataupun kita buat biopsy of the smear lah kita buat. Okay, and then to rule out TB and leprosy. Okay, treatment medical, just kita treat the cause of perforation. So kalau TB kita bagi treatment, kalau syphilis pun bagi treatment. Kita eliminate the source of infection, source of perforation. Small perforation kita buat surgically close with plastic flap. Tapi kalau larger kita kena close surgically ya. Difficult to close surgically, kita kena pakai alkaline nasal douches and application of blunt ointment. Tak sure ni. Okay, so this next one is septal hematoma, which is emergency case. Okay, tapi tak ada sangat pun. So this is perichondrium, nasal septal cartilage and also both nasal cavity ada septal hematoma. Tapi aku rasa ni just kita aspirate je benda ni. Kalau small aspirate, kalau large I'm not sure, tapi kita kena drain lah the blade. Okay. Nasal septal abscess sama juga macam septal hematoma, mungkin dah smaller hematoma yang dah lama kita tak perasan, dia jadi abscess lama-lama ataupun infection, chronic infection cause septal abscess. Okay, so yeah. Okay, ni congenital malformation of the nose. Okay, ni posterior choanal atresia. So dia ada poor development of choana. Okay, kita ada anterior choana, posterior choana. So posterior choana ni dia ada atresia. So the problem ni. Okay. Okay, nampak normal, nampak no passage. Tapi kalau for connectria, which is ada bone blocking, jadi macam tu. Dia tak ada con lah, dia tak ada nasal passage. So jadi bone blocking and nasal passage. Okay. Dalam laptop. Sorry guys. Okay. Ni tak payah tahu lah. Macam dia tak significant sangat.
Dia tengah cakap nak letak di barai.
Dermoid cyst. Okay. Ni nasal glioma. I think this is nice to know kot. Tak payah tahu pun. Okay, kalau encephalocele ni brain ataupun brain punya content dia akan protrude to the opening, so causing nasal encephalocele. Dia ada opening dekat, I think dekat anterior nasal cavity, tak sure part mana, ataupun dekat sinus kot dia ada opening, then dia akan protruded to the opening jadi cause encephalocele. Okay, this is Rhinia, dia memang tak ada hidung so dia developmental problem.
Cuma apa guna apa tu? Guna mulut
Good. So Rhinia tak ada hidung alright. So Polyrhinia lebih kan, Polyrhinia. Okay, ni okay. So kalau different diagnosis for blocked nose, nasal obstruction, nasal congestion. So tengok duration kita dulu. Kalau acute less than 12 week, mungkin this is just common cold, intermittent allergic rhinitis ataupun acute rhinosinusitis. Acute rhinosinusitis pula kita tengoklah ada facial pain ke tak, ada nasal blockage kan. So if ada facial pain tu more commonly in acute rhinosinusitis. So kalau chronic more than 12 weeks, usually chronic allergic rhinitis, chronic rhinosinusitis with or without nasal polyp, nasal deviation, turbinate hypertrophy, rhinitis ini ataupun tumors. Kalau kita nampak yang belah kanan, affected site, kalau unilateral or bilateral. Kalau unilateral yang ada nasal congestion ataupun obstruction, so maybe it just deviated nasal septum ataupun tumor organism mucosa. Kalau bilateral dua-dua dia tak boleh nak dia ada congestion ataupun obstructed, kita consider NPC. Alright. Okay, ni tumor pula. Tumor sikit juga, right. So dia ada banyak source of tumor, source of cell. Okay, so epithelial tissue boleh, from bone boleh, from cartilage, neurological, vascular, lymphatic tissue and also muscle venous. However, the etiology is unknown. Tapi kita ada risk factor for example like smoking, okay, hardwood exposure in adenocarcinoma, HPV infection associated with inverted papilloma. Okay. So tumor punya presentation I think straightforward lah kot. So bila ada something dekat hidung which is besar, they will cause nasal blockage and also patient would have rhinorrhea, nasal discharge and also epistaxis. Maybe it's from the extension of the tumor itself ataupun from the tumor. Okay, and then patient would have facial pain because of the referred pain to the trigeminal nerve. So di trigeminal kita akan dapat facial pain. So hyposmia and anosmia sebab dia dah obstructed, so tak boleh nak travel to the cerebriform plate to the sensory nerve of the olfactory nerve. Okay, so certain features should make one suspicious. So for example, unilateral symptom, unilateral blockage and also unilateral bleeding. So one side only. So maybe kita boleh consider patient ada tumor. Cacosmia, abnormal smelling. Okay, proptosis. Okay, kita punya mata kan. Proptosis is mata terkeluar. Endodiplopia, double vision, epiphora and also neurological symptoms. Macam headache, okay. Alright. So clinical examination kita boleh buat nasal endoscope. Nak tengok origin of the tumor sebab different, kadang-kadang nanti kita tengok different tumor ada different origin. So orbital examination sebab dia dekat nasal cavity, so probability dia nak invade orbital punya content memang tinggi lah. So kita kena buat orbital examination including eye movement. Cranial nerve pun important, especially trigeminal nerve yang tadi kita cakap boleh cause special pain, and also intraoral examination. Okay, sebab dia inferior punya spread dekat inferior punya extension lah. So boleh cause including heart and soft palate, teeth and gingiva. Otoscopy pun boleh juga if patient ada besar sangat and boleh cause obstructed eustachian tube. Okay, ni causes dia. Dr. Ramiza cakap penting semua ni, tapi tak tahu dalam slide ni sikit je. So kita tengok mula ke. Okay, the first one is the benign tumor, inverted papilloma. Okay, it is characterized by inverted mucosal surface. Nama pun dah inverted, so inverted mucosal surface extending into the stroma of the papilloma leads to the term inverted for dia karakteristik inverted mucosa benda jadi inverted lah. Okay, although benign, they behave in locally aggressive manner. So diorang benign, diorang tak malignant, tapi diorang boleh jadi locally aggressive. However, malignant transformation can occur up to 10% of the lesion. Okay, dia memang require wide local excision lah. Memang kita kena buang inverted papilloma. Okay, HPV nampak, HPV infection has been associated with inverted papilloma. So these are the X-ray, CT scan demonstrating unilateral opacification on the right side of the patient. So kita nampak opacification, so maybe memang consider tumor. So belah kanan ni inverted papilloma presenting at nostril. Okay. Okay, clinical features. Okay, it almost always unilateral and presented with nasal obstruction, nasal discharge and expansion. So ni common symptoms of tumor lah. Okay, unilateral, ada nasal obstruction, nasal discharge and also epistaxis. It can invade sinuses or orbit. So orbital symptoms, for example, like proptosis, diplopia, lacrimation can occur. Okay. On examination of nose or endoscopy, it presents as pale polypoidal mass resembling a simple nasal polypus or irregularly fleshy lesion. Okay, dia macam flashy lesion. Okay, that's hallmark lah. So CT scan and MRI, kita boleh tengok for extension of the tumor. Biopsy is essential for the diagnosis. So for treatment, kita buat medial maxillectomy. So approach by lateral rhinotomy. But this day kita pakai endoscopic approach. Okay. And then, contoh dia. Ini adalah kita nak buang apa? Inverted papilloma. Kita kena ni lateral rhinotomy approach lah. Okay, so juvenile nasopharyngeal angiofibroma. Ni common in young teenage boys. Okay, young teenage boy yang datang with nasal obstruction, epistaxis, nasal discharge. So you guys can consider juvenile nasopharyngeal angiofibroma. It arises from sphenopalatine foramen and presented around the nasopharynx. So however, macam tadi juga, macam inverted papilloma, although they are benign, they can have local extension into the skull and also intracranial disease. Okay, nampak tak SPF tu, sphenopalatine foramen. So anatomically, dia orang dekat belakang, itulah, dekat belakang koana semua tu. Dekat area in front of the sphenoid bone tu. Okay. Okay. Okay, investigation kita buat endoscopic examination. Okay, just want to reveal the purple soft tissue swelling. Okay, staging kita pakai fish. And then investigation CT MRI macam biasa, kita nak tengok extension. Okay, biopsy should be avoided because patient would have severe bleeding. May be accounted with the biopsy. And then the classic finding on CT scan is anterior bowing of the posterior maxillary wall, known as Holman-Miller sign. Tengok ni belah kiri kita. So dia ada anterior bowing of the posterior maxillary wall. Okay. Nampak yang belah kanan tu dia dah extension to the cranial lah. Dia dah masuk intracranial cavity lah tu. So memang common lah patient ada intracranial punya extension. Okay. So this is staging. Korang boleh baca ni. Okay, for treatment kita memang surgery. Okay. Open external or endoscopic approach. Okay, smaller tumor may be resected successfully endoscopically, but usually kita buat open approach because they have greater access to the field. So kita ada greater punya view and then, but may be very bloody lah. Okay. So the melanoma is very rare of nose and parodontal sinus. So age, gender of males over 50 years of age, inhale carcinogen which is smoking, and also adenocarcinoma of the ethmoid sinuses. Woodworker. Okay, squamous cell carcinoma. It may arise from the vestibule, anterior part of the septum, or the lateral wall of nasal cavity. Okay. So in patient yang in vestibular origin, it arises from the lateral wall of nasal vestibule and may extend to the columella. Okay, yang dekat tengah-tengah ni. Nasal floor and upper lip with metastasis to parotid nodes. Kalau septal punya origin, mostly arises from mucocutaneous junction and causes burning and soreness in the nose. Nose Picus cancer. Lateral wall, this is the most commonly involved site. Okay, easily extend into the ethmoid or maxillary sinus. Metastases are rare. However, treatment is combination of radiotherapy and surgery. Okay, these are the right nasal cavity contain many bleeding tumor. Okay, next adenocarcinoma is related to hardwood exposure, but other carcinogens such as nickel and chrome pun boleh consider. Okay, they tend to originate in ethmoid sinuses and in the region of middle meatus. Treatment, craniofacial surgery. Okay, alternatively, apa ya? Okay, malignant melanoma. Grossly it presents as slightly grey or bluish black polypoid mass. Side the anterior part of the septum followed by middle and inferior turbinate tumor spread by lymphatic and bloodstream. Cervical node metastasis may present. Treatment is wide surgical excision. Tak sure lah. Dalam. Okay. Tak payah. Nice to know. Olfactory neuroblastoma.
MRI.
Okay lah guys. Tu je.
Okay. Bentar. Syafiq.
Tadi guys, tadi yang malignant melanoma, radiotherapy and chemo are avoided because immunological defenses of the patient play a great role in the control of the disease.
Maksudnya?
Malignant.
Malignant kan.
Maksudnya?
Tapi chemo, radiotherapy tapi chemo boleh kot. Chemo je lah.